right. Welcome, everyone. I'm Mariset Hassan with the South Carolina Coalition for the Care for the Seriously Ill. For those of you who may be new, we have been in existence since 2010, originally hosted by the South Carolina Medical Association's Bioethics Committee. At about 2016, we transitioned over with a new backbone, the Carolina Center for Hospice and End of Life Care. And currently, we are with Health Sciences Health Innovation Group, who is our benefactor and backbone for North Carolina and our South Carolina Serious Illness Coalition. It is our great pleasure to have hosted this virtual symposium this week. Our theme has been From the Heart, and it has been heart failure and the care continuum. It's been a wonderful week of learning and also inspiration as we were kicked off on Monday with Michael and Crystal from Prisma Health, really sharing about some of the innovative and supportive things they are doing for advanced heart failure patients through the Prisma Health Center. They are certified as a clinic to do that. And then on yesterday, we got a slice of what's happening nationally in terms of the work that American Heart Association has done to really put together some clinical criteria around when is the right time to make a referral for heart failure. Today, we are privileged to have our very own folks from the Carolinas, Cara Nova, who's going to be really sharing with us a very innovative program that's being implemented now, a comprehensive palliative care program for serious illness serious illness patients, and what this care model looks like. They are going to share with us what has been going on from the inception, and now we're in the middle of it. They've already launched it. Now, I want to share with you that we are recording, and we also will provide the slides to you. We will also ask you to evaluate our program and give us any feedback from what you received, as well as to tell us about other topics that would be of interest to you as we continue to round out our educational programming for the rest of the year. Also want to take a moment before I turn it over them to our guests to let you know that South Carolina Governor McMaster has declared that this is Healthcare Decisions Month. And so we have a proclamation that's out there. I want you, and know many of you are encouraging patients to execute their directives, but we also want to talk with our healthcare providers as well. Sometimes we leave those things on the back burner, and we're talking to other folks about getting their plans in order, getting their house in order with their healthcare directives, and we haven't done ours. And so I do know that there are some things going on around the state in our health systems to really bring more awareness to employees, as well as outreach work that we're doing in communities, libraries, churches, aging programs, you name it. Folks are out there during this month really encouraging folks to, number one, have a conversation, and number two, to take that conversation to the next level and to execute an advanced directive. So with that, I am going to turn it over now to our friends. Let me introduce them to you. First of all, we have Dean Higgins, who is the Vice President of Health Transformation at Cara Nova. And Dean oversees all the programmatic and care transformation portfolio for Cara Nova. He's providing a lot of the operational and strategic direction as a part of that senior executive team. Now, Dean has over 25 years of diverse healthcare experience from community-based behavioral health, managing business operations for community-based hospices. We'll have to talk about that, Dean, because I'm a girl with a hospice background. Love it. Love hospice, even though now I'm doing some different kinds of things, and has been very key in leading some health improvement initiatives. We also have joining us today Dr. Christina McDaniel, who is the System Executive Director for Palliative Care. Christina's been a nurse for over 20 years, primarily focusing on leadership and innovation in areas related to palliative care, hospice, population health, pediatrics, etc. In January,
while they're introducing you.
I'm going to ask if you can, those who may be with us, to mute your lines, if you will. In January of this year, Dr. McDaniels is now serving as the executive director for palliative care for the NUSC system, and so very integral to this part. And to round out our panel today, we have Laura Rogers. Laura is a value-based program administrator with Blue Cross Blue Shield of South Carolina, and she has over 18 years of experience in the healthcare industry, with her current focus really looking at payer-driven value-based care and provider innovations. So I love this, that she shares that when she's not operationalizing innovative concepts, she can be found on adventures with her family, which all of us need to take more time to have adventures with our family. So thank you for that, Laura. That's a good reminder for the rest of us. So without any further ado, I turn it over to you guys. Thank you.
Dean, you're muted.
Oh, not starting off on a good foot, am I? Well, I was saying thank you, Mayor Seth, for that wonderful setup and introduction. We're really excited to kind of share our work with you all today. If we go to this next slide, just kind of share our agenda, what we want to accomplish together over the next 60 minutes plus. So you want to start off by just sharing some who we are, just I think does some level setting and context setting on who we are as an organization. What are we trying to accomplish? What does our approach look like overall, then specific to serious illness care? And then I think the most exciting part of this presentation, I'll start us off, but is really hearing from both the provider and the payer perspective on how we're all collectively working together to pilot, test, and implement this approach. And so there's a lot of great work that's happened over the past year. You'll hear from both Christina and Laura just from their perspectives and how we kind of tie it all together. So having those unique perspectives, and then at the end, the three of us will share some of our observations and what we say are lessons learned, as we're again about a little over a year into this now, that are informing like where are we at now, and then what's the path forward as we kind of work together to grow this work and demonstrate some outcomes that really set up a path for sustainable with payment model, but also a system of care delivery system that will benefit patients in the Carolinas. So excited to share some of those lessons learned, and then we'll leave plenty of time for Q&A for any questions you have. I would ask though, and I'm sure my partners on this call would also agree, that if you have questions, go ahead and chat those in, and we'll try to get those queued up. And if we see some of those, Anna will try to help flag some, and we're happy to address those in the moment. But if not, we'll definitely address those during the Q&A portion. So the next slide, Mayor Sett did a wonderful job of introducing us, and then as we each present, we'll give a little more context to who we are and how we fit into this work. So as I get started on the next slide, just so the introduction of CareNova a bit further, in case you're not aware. So CareNova, we're an independent nonprofit organization, a small organization working across the Carolinas. And what we do is we test and scale solutions aimed at redesigning the entire health ecosystem, and with the ultimate goal of improving health for all Carolinians, so across North and South Carolina. Our approach is we deploy what we refer to as cross-sector collaboration, bringing together all the key stakeholders across the Carolinas and really at the national level as well, to spark innovation and transformation in healthcare. And so we see ourselves as neutral conveners. We don't have a defined necessarily advocacy or policy agenda, but we do adopt those policy and advocacy priorities that align with the topics and the problems that we're trying to address. So we can be that neutral convener and facilitators that bring the key stakeholders to the common table and keep folks at that common table to work together over a period of time to, again, both identify what are the solutions that are already out there and that we can work collectively to test and implement. So as that connector of what we say people and ideas, we're working with healthcare providers, we're working with payer community, the policymakers, community health advocates, and also patients to test and evaluate those promising new and established practices that will help us get to develop that business case. So there's business models that ultimately allow us to scale and sustain a successful model or solution for systems change. So It's gone beyond deploying grant funding and doing good work to how do we leverage grant funding, seed funding to test and evaluate and to get to a sustainable solution that allows that impact to stick over a long period of time. On the next slide, if you think about how our approach to the work. So because we're really trying to impact the entire health ecosystem, we take a longitudinal approach to systems change, which starts with cultivating ideas. And that is really recognizing that every community has untapped ideas and potential. So we're working systematically to understand and identify those regional needs and solutions that are typically common across the Carolinas and really nationally. So as I'm sure all of us are familiar with, we start with researching the topic, doing that deep dive landscape assessment, a gap assessment, and really defining the problem before we jump into solutions. And spending the time on the front end to really have that deep understanding, bring the right stakeholders together, those different groups that we mentioned in the prior slide is important because we use that to develop what we call an opportunity framework. So what are those, again, those solutions that are most likely already out there that we can bring together, create a framework around it and evaluate it, and then do some pilot testing. So in that cultivation phases, we're really kind of learning deeply and then creating what we call that opportunity framework and a roadmap for success. Our next major phase of our process is we co-design solutions. Once we have a theory of change and an opportunity, again, making sure the right individuals are at the table. What can we test on a very small scale? So one payer, one provider, one community to learn from, and then we can really help us to validate, refine before we start scaling and moving to some sort of larger scale adoption of what it is we're trying to implement. So that's where we are right now. We'll talk more about in the serious illness space. We're in this co-design phase where we have this very active pilot, and we're learning a lot starting in South Carolina and starting to spread that learning to North Carolina now through this what we're calling this CPCSI, the Comprehensive Palliative Care for Serious Illness Pilot. And then finally, once we've kind of have proof of concept, we've have outcomes, we've validated this is feasible and it's scalable, is when we move into our catalyzed phase, and that's where having payers at the table on the front end during cultivation and co-design allows us, by the time we get to catalyze, there's buy-in. We've hit certain business objectives to say, can we implement some sort of policy and payment reform that really helps move this beyond, again, seed funding from a philanthropic funder to some sort of sustainable change. So that's what we're working towards. We're not there yet in the serious illness space, but that's our ultimate goal, is that catalyzing the change that we're testing right now. So this a little kind of gives a bit of a little more detail in how we think about that cultivation phase. So around serious illness, this topic, it really in the late 2019, early 2020 is when Carinova started to really look deeply into this topic area, and mostly through the work with the Duke Endowment. As I think a lot of folks on this call know, that the Duke Endowment has been a longtime funder of serious illness work and palliative care work across the Carolinas, and have seen a lot of great outcomes that have come out of those programs. But what we've learned is that a lot of that improvement and learning happens in a silo. So part of the reason for creating Carinova was to de-silo a lot of that learning, and how can we kind of synthesize what's happening in those individual grants and programs and kind of create some sort of broader kind of systematic approach. So we spent a lot of time doing stakeholder interviews and learning from those other, again, grant programs. What were their outcomes? What were the lessons learned? What are the ongoing gaps? Then we can kind of build into our approach. So we, again, can work with those folks that have been in this space for a while, but help move it forward through something more sustainable. So, I mean, and the other piece too is, on the next slide, you can see that part of our strategy was making sure that we're not leaving out those with lived experiences. This was a really creative, what we call patient journey mapping, where we brought together providers, but also patients and caregivers to talk about what's most important to them when we think about that serious illness journey, and how what are their goals, what have been their pain points, and if we're designing a new system and we're making sure that it meets, most importantly, it meets patients' needs and patients' goals, what is most important to them, and what do we need to factor in as we're designing a new system. So this is we'll make sure you have these slides after the fact, but I think it was a really creative way to kind of map out what we're hearing from both patients and caregivers. So on the next slide, we talk about what is, as we designed this pilot and, really kicked it off at the beginning of last year, starting with our theory of change that really drove how we evaluated and measured success. So our theory of change is that we believe that if we can establish and spread the adoption of what we call high quality, comprehensive, and mostly community-based palliative care services in the Carolinas, supported by, and this is really important, that value-based payment structure, we can and we will achieve better outcomes, patient outcomes. We can reduce disparities both in access and outcomes. So that's very important to us, as we're making sure that these services are available and high quality service to all populations, and that we're improving the patient experience and the provider experience. We can achieve lower cost and uh, get to broader payer adoption to sustain the model, both private and government payers. We're obviously is our focus. Our opportunity. So through, again, what are we trying to achieve through this pilot work, is that we're using a very iterative, deliberate pilot to pilot, validate, refine, and spread our approach. We're really focused on these kind of four key objectives. So, looking at what are the standard services and operations that need to be in place on the provider side. So we want to make sure that we're testing what is a standardized criteria, so that eligibility criteria for who qualifies for these services, that also helps with more upstream, earlier identification of those patients. We're not trying to overprescribe, but we want to develop what are those minimum standards of care delivery and coordination that need to be in place, that would need to be built into a future value-based payment model. So again, it's to create minimum standards that then allow for flexibility between different types of providers that may have some allowable variance based on how their programs are structured, but what is the minimum that gets us to the outcomes we're hoping to achieve. We want to provide that evidence. There's been a lot of pilots that been conducted nationally, and what we've heard is that where they kind of stall out is around the evaluation and the available data. So we've developed a very robust data measurement and evaluation structure for this pilot, so that we can provide that evidence to the payer community for that ongoing reimbursement, and what does an effective value-based payment model look like, that where the incentives are aligned across both payers and providers. And then the last, but definitely not the least important in terms of goals, is that framework for payer-provider collaboration. And you'll hear from both Christina and Laura just what that looks like, and just how valuable that's been in this pilot, of how we intentionally create a structure where creating that collaboration between the payer and provider on the identification, the care, the management, the monitoring of that patient population is critical to our success. So this slide speaks to the framework, and we often refer to as a model, but it's really the framework that we've put together, again, through that cultivation phase, where we really learn from our stakeholders of what are the components that we need to put together that would be tested in this pilot approach. So again, I would say informed by established, really evidence-based services and care pathways, we created this model that really follows a patient from that early identification uh, through their, assessing that patient, providing a treatment plan, and then, all the way through that disease progression through end of life care. Now, the program that we've developed, it would end when a patient would be eligible or elect hospice services, but we're trying to think of what is that trajectory that a patient would follow from diagnosis all the way to end of life. Focusing on the front end, you see we have our patient identification filter that establishes what is the how do we have a process for early patient identification using, as I mentioned, a standard filter that focuses on specific disease states. And we'll talk about that on the next slide, what our filter looks like, how it's designed, what is the functional status of that patient that would qualify them for services, and the utilization that would be part of those three kind of elements of our filter, and then creating workflows around that to support both payer and provider and how those patients are identified and how they're engaged, and both the patients, but also the providers, and how we're helping the providers to better identify and engage those patients who may meet this criteria. It also focuses on appropriate training and equipping clinicians to have those earlier and honest conversations with the patients about their prognosis and treatment. You can see some of those in those yellow goldish triangles, or the diamonds, sorry, that kind of speak to the importance of those conversations early on, kind of pre-palliative care, and then as a patient gets closer to end of life. It's also centers around the interdisciplinary team, the clinical team, but also those non-clinical supports, and how that team works together to manage the goals. And again, where we layer on to the family. And one of the unique pieces that we added to our model, and it was informed by our what we call our topic action team, again, the subject matter experts, was that there's often not much focus on legal and estate planning for patients that are, have high disease burden and this population. So what does it look like to, those who have, for estate planning, for example, can we connect them with resources? And some of that also gets back to the health equity piece, because that transfer of wealth for certain populations that's not focused on. So can we add that as an element? Because we know that's important as we're thinking about someone's holistic needs, that we need to focus on that as well. So that's a unique element that we've added into our program. The other piece here, just as we're looking at this visual, is, this really is a focus on value-based care transformation, where, our current model is we provide palliative care, but it's under a fee-for-service structure. So it's not, it's hard to do in a comprehensive way because it's not reimbursed in a comprehensive way. So by creating the payment mechanism for it to be comprehensive requires that value-based, pop health transformation focus, where we have to build those standardized clinical pathways and workflows. We have to optimize the use of the interdisciplinary team. That shift from physician still is the physician is the lead, but also more nurse case management driven. How do we stratify and do risk stratification with our patient population if we're operating under a value-based care model? And then having robust data analytics to support, again, both patient management, but also quality and performance monitoring, because that's what we need under value-based contracts. Is, are we hitting certain, quality goals, and are we kind of meeting both our, as providers, our targets, but also what is important to the payer as, we're working under those value-based contracts. So I just want to kind of highlight that, because that's I think important as we think about what are we trying to accomplish as we move from that fee-for-service to value-based landscape. On the next slide, this is what I was mentioning about our patient filter, and won't walk through every component of this, but it gives you all the 8 disease states that we are part of our inclusion criteria. We just recently expanded the cancer diagnoses, and I think this is a good example of learning in the moment, where we start with a system and an approach, but we allow for it to be adaptable. And it's why we're piloting on a very small scale, because we want the clinical teams to say, where is this filter too restrictive? Is it too broad? And then have a very defined process for if we're making recommendations to change the filter, and then how do we get that approved? Since again, this is really a collaboration between the payer and provider. So we'll talk more about the governance structure that helps us with that in a few minutes, but I just wanted to highlight that is that we're using learning to make those changes real time. But again, it's those 8 disease states, looking at the utilization, but also the functional status of the patient to determine eligibility. And so really we say if they meet these criteria, that they have, you know, they have a 40% chance of mortality in the next 12 months. And, I think as we get further along, we can even be thinking further upstream. But again, it's what are those patients well before hospice eligibility that would qualify for these services. So on the next slide. So as I mentioned, we are in just really entering year 2 of our 2-year pilot. And so I wanted to kind of just touch on our overall strategy that we put together for how we're approaching pilot testing and really what the goal is beyond that. So the structure of this is that one, the Duke Endowment is providing the initial grant funding, and we are looking at other funders who would want to support this to help us scale this, beyond where our kind of our current pace. But they're providing 2-year grant funds, and we do an assessment of readiness on the provider side that have some kind of core services and operations in place to be able to engage in this pilot and be able to launch in a relatively short period of time. But again, starting with a one-on-one payer provider focus, and we, as I mentioned, we started in South Carolina with Blue Cross South Carolina and MUSC. But both are just worth mentioning on our Care Nova's advisory board. So there was a very logical kind of start there with readiness to that be our first entry point for the pilot. And although we're focusing on a defined population with that initial payer partner, this is a payer agnostic enrollment approach. So on the provider side, they're really thinking about all patients that, regardless of payer source, that would meet the criteria, because we want to make sure that as we're evaluating the outcomes with that payer partner, we're also doing a broader evaluation of what is the impact of these programs for any patient, regardless of their payer source. So as I mentioned, to make this work and to make sure that we create some structure and some help with kind of who needs to be at the table and decision support, we created a governance structure. Care Nova kind of right now in the pilot is helping to oversee that governance structure. But the goal really is once the pilot is wraps up, that governance structure between payer and provider persists, so they have a way to continue to work together, and Care Nova is kind of steps out. So we created, operations steering committee. We have work groups that address specific areas around what does engagement, enrollment of that patient population look like, the clinical operations, as well as kind of data analytics. And we have quarterly executive operating committee meetings between payer and provider. Again, Care Nova helps to kind of broker, facilitate those discussions, but really looking at performance and where do we need to make those adjustments real time. Our role also, just moving down the rows there, is to provide technical assistance. So as I mentioned, we created a readiness assessment and planning process, and then based on that assessment, what does onboarding look like for both payer and provider? So that's really kind of helped create that structure as we think about scaling this to other providers, other payers, that we've kind of have that down of what does it take to implement this program. And so so there's that technical assistance and coaching that we provide, but also like I said, the data and evaluation piece is huge, collecting a lot of data, patient level data, to again drive decision making, but also provide the data that we need at the end to make the business case for a new payment model. So we'll speak about evaluation on the next few slides, but this is an outcomes-based evaluation, but we're also obviously looking at both kind of quantitative, qualitative metrics, and using that for our learning, because as we think about as we're validating this model, we need to make sure we can replicate it in different environments. So we're starting with a large academic medical center. What does it look like in a smaller community-based hospice palliative care provider? And again, so it should be able to be transferable to different settings and different types of providers. On the next slide, so just taking a deeper dive into our measurement and evaluation uh, approach, really, and this is for all of our Care Nova initiatives, we look at 4 quadrants of how we evaluate our programs. So, and this is tailored a bit to our serious illness work. So we looked at improved outcomes. We're obviously the improved pain and symptom management for the patient population, but also looking at decreased utilization and more appropriate utilization. So are we seeing reduction in ED utilization, uh, and then also readmissions is also one of the key outcome metrics that we're looking at. So as I mentioned, as we're kind of going down below that, reduce disparities. So we make sure we're creating a system that is works for all, and we're not unintentionally widening the disparities gap. So we're collecting a lot of data, and we're able to drill down on those variables. So like the real data to see, if we're comparing the demographics of our catchment area, how does that compare to the demographics of the payer population? So right now we're just focused on the Medicare Advantage population and doing that comparison to see are there certain populations that aren't we're not seeing enrollment, and then if so, what do we do about that? And then thinking about the communication and engagement of those different populations. And I know there's a lot of great work happening in the serious illness coalitions of both states for, how do we work with faith communities? And, I think that also informs in this pilot, just different innovative approaches to, just that communication and engagement. As I mentioned, the other main goal is the increased patient and provider satisfaction. So we're looking at meaningful metrics like not just satisfaction, but experience of care. So using surveys and assessments to, are we meeting patient needs? Is pain being adequately addressed? And then from the provider side, are these services, meeting their needs? So to make sure we're getting the provider perspective as well. And then finally, as we mentioned, the return on investment, since we're trying to that part of that sustainability is, are we making the business case? Are we showing those shifts in utilization? Based on a lot of the national evidence, there's a lot of good data out there on the ROI. So, we're very hopeful to see similar or even better results in this pilot. And again, ultimate goal is to getting to a new bundled payment rate that would sustain these services long term. On the next slide, and I want to try to wrap this up because I want to make sure we get to Laura and Christina. This just kind of, again, from an evaluation approach, I'll just quickly run through this. There's 5 key questions that we're trying to answer through our evaluation. So again, did the patients and the caregivers have a positive experience of care? We mentioned the surveys that we're working with MUSC on developing and administering to capture that data to answer that question. Looking at that quality of care, and again, we can look at the assessments that are being completed. So we're collecting the data on those, and then the services that are we delivering the right services under a new bundled payment rate? So we're collecting a lot of data around those patient encounters. So we have that data that's coming in that's part of our measurement system. And then the return on investment, how much does do the services cost if we're bundling those? So looking at the revenue and encounter data, and we just recently kind of talked through with the structure of that financial model, and so making sure that we have the right financial and encounter data to kind of validate that new payment rate. So if you look on the next slide, this speaks to, I think, this kind of at a high level. We look at it in 2 major phases. So as I mentioned, we're in the second year. So the first year was really looking at feasibility testing, collecting a lot of data, in implementing kind of new processes, new workflows, making sure that we're collecting data that represents fidelity, what we say fidelity to the model. And I think we made a lot of progress, and Christina and Laura can speak to this. So we can start modeling that case rate and that new bundled rate. So again, year two is really about looking at those outcomes and creating that new payment model that we can kind of test and adjust as need and refine as needed. So as I mentioned, it's about creating those minimum standards. It's about the payment rate, but also those minimum standards of care. And this year, 2025, and really into 2026 will be, now that we have a good sense of what that looks like, just testing that out, enrolling more patients into the model, so we then have the data to just really validate that moving forward. And then the last slide I'll share before turning it over is, and I think this is important to highlight, as I mentioned, this payer-provider collaboration framework we feel is really powerful in making this work. And again, as we spread this out, so we want to make sure that and the bottom arrow I think is important, because as we've been working through this again in very much a co-design fashion. So at every step, it's working, that operations governance group has been representation from MUSC, from Blue Cross South Carolina, and from Carinova to kind of work collectively on designing the systems for how do we do a better job identifying and enrolling those patients. Once they're enrolled, what is the management? What are the resources, and how do we deploy that resources to manage their care and have a robust care plan? And part of that too is in that oversight monitoring, that the connection between the clinical teams on the plan and the payer side working together, and communicating. So, it's not about just getting a claims list of eligible patients from the plan. It's about those care teams working together. And a lot of times that's where we're seeing those patients are identified through that collaboration between those care teams. So just want to highlight that, is that working together is, I think, what is we're seeing is key to the success of the work moving forward. I'm gonna stop there, because again, I've spoken for a long time, and I think now is that's a good setup for turning over to Christina, who from the provider perspective can speak to how they're structured and how they're approaching it.
Thanks, Dean. Yeah, and I would just echo, and I'll say this too, in part of my presentation. Just there are a lot of exciting parts to this pilot and what we've seen so far. But I think one of the most exciting things that we've seen is this partnership with the payer, and what a difference that can make in getting patient services that they need in a timely manner, and the nuance of that conversation too when it's coming from a different source. So we'll talk about that for sure. But Anna, you can go to the next slide. So I don't ever miss a good opportunity to make sure people understand what palliative care is. I don't ever take that for granted. But so just, why we see the value, and especially doing these kinds of partnerships and really looking at how do we justify what it is that palliative care does? What are these outcomes? How do we see an impact to patients and families, and also their utilization of resources? And so understanding that, I think our biggest hurdle a lot of times is getting consults, getting referrals from different sources in a timely manner, not when the patient is nearing more of that hospice phase of their trajectory, but early on in their serious illness is how we see the biggest impact. And so this slide just highlights that it's based on the needs of the patient and not the patient's prognosis. That's usually my 2-second elevator speech anytime I talk about palliative care. So we can go to the next one. And I think too, what this work has highlighted for us as well is, why are we doing this? And it's because failure to proactively address these needs in patients who are facing serious illness and their caregivers causes so much unnecessary suffering and cost that really aren't necessary. And so, understanding that half of these older Americans visited the emergency department in their last month of life, and even 75% of them did in the last 6 months of life, when their outcomes were likely not improved by any of that utilization. And so, seeing the impact that palliative care can have from that component even is really powerful. But that it cannot only be provider driven, it has to be an interdisciplinary team approach as well, which is what we know makes palliative care so unique in the offerings that we have. And projects like this are helping us to prove that really, in order to do effective, comprehensive palliative care, we need a whole team and not just for it to be provider driven. And that is a change in framework. That is a change in the way that we look at how interactions with patients are driven. So we'll talk about that too. So you can go to the next slide. So just to give a little bit of background on MUSC as a palliative care program and our road to comprehensive palliative care. So we were established really in 2015 when Pat Coyne joined MUSC as the director of the palliative care program, and started to stand up an inpatient palliative care consult service. So that team was established in 2015. Then we saw the need to really look at how do we get palliative care services across South Carolina where they otherwise might not be available. And this also coincided with a large expansion from an MUSC system perspective. So whereas we used to only be based in Charleston, we started to spread out across the state with smaller, either rural or regionally placed hospitals that were serving patients where they were so that they could get a level of service otherwise they may have had to travel for, to places like the peninsula, which I joke no one ever really wants to come to the peninsula, but other than to maybe go on a boat, but certainly not from a travel perspective. So we partnered at that time with the Duke Endowment to start a statewide telehealth program, and have seen, I think, what even surprised us, and a huge uptake of these services, even over a modality like a video screen, because access is an issue. And so as we do this work, even that's continually what we see. It's access to these level of services that continue to drive us in looking at how can we do this differently? How can we do this in a more comprehensive way? Right now, we're probably upwards of about 2,400 palliative care consults across South Carolina in an inpatient setting through telehealth. And our ambulatory program, which is where CPCSI is focused, and was established really in 2019 on a very, very small scale with one advanced practice provider and only a quarter of a physician, also see a very high number of virtual-based visits. And in 2022, right around the time that we were having conversations around this type of project, and I was very early involved from a content expert perspective in what Dean talked about, we started to understand that we had to move forward with expanding our ambulatory team. But again, how are we going to do that? Because of course, we feel strongly about this interdisciplinary team approach, but getting the support for that is sometimes very challenging. I won't say sometimes, a lot of times, very, very challenging. And so in 23, when we came into this collaboration with Blue Cross Blue Shield and with Carinova, through, again, support from the Duke Endowment, we were able to support the expansion of our team, and the addition of a chaplain, a social worker, an RN coordinator, so that we really did have this comprehensive palliative care program to offer patients and to measure the impact of that level of care. So it's really always really great to look back where we were and how we've gotten to where we are today. But a lot of that is through mechanisms like this, where we have these collaborative partnerships that really afford us the ability to prove what it is that we know, and that's the impact that palliative care can have on serious illness patients and their families. So you can go to the next slide. This is just a snapshot of where we are now. So from an adult perspective, we also have a peds portion to our team, but we won't talk about that today. But we have an inpatient team made up of these particular disciplines. Our clinic and outpatient team that you see in the middle, that's really where CPCSI lives. We do have home-based visits through a collaboration with MUSC Home Health. So we partner with that home health group to either utilize their nursing staff on a PRN contracted basis if we need to have them seen in the home, or if they are already being seen by a home health provider, we can do that collaboration to see what is actually going on in the home. But again, around 68 to 70% of our visits are done over video. And so, there is a lot of benefit to that for patients not having to drive to a physical clinical location that's maybe out of their area to have this access to a palliative provider and the team. And again, also providing 24/7 call coverage. So when patients or families have a need, it isn't, we all know that needs don't just happen from 9 to 5, right? So, or even 8 to 5. And so having access to a provider that covers a pager 24/7 if there were needs. But I'll say that what we've seen is with the addition of RN coordinators, especially, a lot of these needs can be met during regular business hours. It's proactively managing those patients really does lower that need for on-call coverage. So again, just another example of painting the picture of why an interdisciplinary team is very necessary. So you can go to the next slide. So this gives a snapshot just of how many patients are we seeing. So active patient census right now for our ambulatory team, we're actively following about 780 patients that are palliative patients, and they range in an acuity to patients who only really need to see us maybe every 6 months to patients who are seeing weekly because we're symptom managing them and titrating medication. So it really depends on the need of the patient. And I think this project that we'll talk about this in just a second has really helped us to think through the stratification of those patients and how do we allow that to drive the utilization piece as well, even from a palliative perspective. Right now, we have 103 active patients on the CPCSI panel, so part of this pilot project. And I just wanted to highlight how many visits we're doing. So total visits over from July the 1st of last year until now, 2,848 total visits, with 65% of those being over a virtual modality. So you can go to the next slide. So since we're talking about heart failure patients, I thought it would be good to just give a snapshot of what our palliative care cardiology footprint looks like. So we embed within the cardiology clinics in Ashley River Tower downtown 2 half days a week. 1 half day is dedicated specifically to pre-LVAD or transplant consult patients. That's actually required from an LVAD accreditation standpoint. So, however we get in the door, that's great. So if it's part of an accreditation, that's an easy entrance into making sure those patients have a palliative consult. But we see a lot of benefit in that because not every patient is going to be a candidate for an LVAD or for a transplant, of course. And so if they've met our team, then the connection to that team, especially after they've been deemed not appropriate for those interventions, is highly impactful and important. And then the other half day a week, we strictly see heart failure patients in that clinic in person and over video visit. All of our LVAD and transplant consults are done in person. So that is a strictly in-person clinic, mainly because they're there for the workup and they're already on campus and seeing other providers as well. So that's a true embedding into that cardiology space. We also have a Rutledge Tower primary palliative care clinic on the peninsula, and cardiology patients can be seen in that clinic as well, especially if they have established care already with our provider or providers. They can do their follow-up pretty much in any setting that works for them logistically. We didn't want access to be a barrier just based on their diagnosis. So but again, virtual direct to consumer visits make up about 65% overall palliative care patient visits. One antidote that I will give with this particular population is that we see an extremely high no-show rate for initial visits in cardiology patients, specifically heart failure patients. And we believe what drives that is the timeliness of palliative care referrals. So that's just something that we have seen when we look at the length of time that that patient has been followed by a cardiologist for their heart failure, has had a known heart failure diagnosis, and how long into that trajectory they are being connected with palliative care directly impacts their show rate from an initial visit standpoint. The other piece to that too is that what we talk about in these serious illness conversations and the need for educating consulting providers on at least the ground level of serious illness conversations is that we get many patients referred to us that no one has said anything to them yet about a palliative care referral or what does that mean. And so it really does highlight the importance of the partnership with whoever is sending that consult so that we can make sure that patients are well informed of why they're coming to us and that it is not hospice, that this is not that, many times we hear things like, I'm afraid my patient will think I'm giving up on them, and things like this that really create barriers to getting patients seen. And the other reason that they don't show for their appointments is because they're back in the hospital. And so they're at a level of their illness where they're very sick and they have lots of symptom burden. And so they seek care for that in the hospital setting prior to us being able to see them in clinic. So just a lot of nuance to many of these very seriously ill patients and the importance of timeliness, but the importance too, I think, of supporting consulting physicians and providers in how to have these conversations prior to even sending their patients to us is really important. Also, you can see, based on the number of palliative care referrals from July to March, we had 1,512 referrals come in. Only 11% of those were actually referred by a cardiologist. However, 26% of our patients are heart failure patients. So that again shows that the cardiologist is likely not been the one to refer them. It could have come from a primary care or another specialist who's managing another comorbidity. So it just, I think, highlights for us in this particular patient population the importance of having collaborations between consulting teams and the palliative care team and supporting them in how to have these conversations. CPCSI specifically, we're currently have 23% of our population are cardiology patients and have a cardiology diagnosis. So you can go to the next slide. So this is a really busy slide, and I'll apologize ahead of time, but I think it's important when we're talking about the engagement and enrollment workflow for this particular project. What we learned very early on is that determining eligibility is based on that criteria that Dean introduced a couple of slides ago, but there is nuance in how are these referrals received. And so the, excuse me, the column on the left side of your screen that says eligible at the top is when these referrals come in. So right now we're receiving those referrals in two ways. It's either our normal pathway of a referral that comes through Epic or comes from a primary care or a specialist. And then the other way that we're receiving specifically is through Blue Cross Blue Shield that generates a list of eligible patients within their particular population. And as Dean spoke to learning as we go, we very quickly realized that engaging those patients, so this outreach and engagement portion, the yellow and the red, is definitely impacted with how those referrals are received. And also, it highlighted for us that in some instances, it's not so different, because if the referring physician on that other side has not had this conversation, many times we're having very similar conversations with these patients. And so, I think what we've highlighted in the work that we've done in the collaboration with the Blue Cross Blue Shield case management team is, again, the importance of that collaboration. When someone is referring a patient in, connecting with them, getting the acuity of that patient as they see it, and then being able to use that to say, okay, this patient is actually urgent, needs to get in much sooner. There are a lot of pieces that go into and are solved by that one-on-one collaboration. I know that our case manager, our RN case manager, and Blue Cross Blue Shield's case manager that speak on a weekly basis as part of this project have seen so much fruit come from that collaboration. The two of them get on a call every week. They discuss this list of patients. Otherwise, that would be to us just a list of names, whereas the connection with the case manager is, I've had a conversation with this family member, or this patient has had higher utilization. They've been in the ER several times. And so it really does, even on the onset of that eligibility, help us to look at stratifying that patient to make sure that we understand their needs when they're coming in. And it also gives us a connection with that patient, because when our RN care coordinator, case manager is calling that patient and family to schedule this appointment, they know some of the things that have been going on. They can have a very robust conversation with them, talk about what is palliative care, why is it important to them based on what their diagnosis is and what they've been going through. And it really does impact that engagement piece and the enrollment piece, because part of the gap is we may outreach them, but they never call us back. We never get that patient scheduled for an appointment, or we do get them scheduled for an appointment and then they don't show up. And so we've seen that Jess, our RN coordinator, calling and having these conversations, she says to them, I will see you in your first visit. I always try to attend the initial visits, and it's a connection for that patient. So nobody who's done palliative care is going to be surprised that this is all about relationship building and that connection for patients and families on why do they need this. So you can go to the next slide. I just wanted to Dean talked about some of these meetings that we're doing and how we're tracking this information over time. And so this is just to give you a view of what that looks like. So we meet quarterly as a big collective group. We call it our Executive Oversight Committee, and our data is establishing these dashboards. And so we go through this on all enrolled patients. We look at their enrolled conditions. We look at their where they discharge. There are particular discharge reasons for patients within this program. How successful are we being in outreaching, engaging, and then enrolling, that last step of the process. Very, very helpful too, information around demographics. Where are we seeing gaps? Are we reaching the demographics of the state of South Carolina? Are we really reaching patients that represent the overall population of South Carolina when we talk about care gaps and equity and access? It keeps us accountable to make sure that we're doing also the steps that we need to outreach maybe some of those populations that we don't see represented within those demographics. It also, we'll talk in a minute just about encounters. So what we've seen and what's been unique for us is not only were we, and if you want to go to the next slide, it might be easier to talk through this way, but what we saw was this was a transformation in clinical practice for us. And so where fee for service really drove this very provider heavy care model, we see and we already know the benefit of having an interdisciplinary team. And so, how do we reframe our practice that it may not be a provider, a physician, or an advanced practice provider that needs to see these patients every single time? And so, not only were we expanding ambulatory palliative care, standing up an IDT team, but we were also trying to shift our mindset to value-based care as it relates to the involvement of the interdisciplinary team. So when does a chaplain need to be tagged in for that patient? And maybe that doesn't need to be a provider and a chaplain meeting with that patient together. It really needs to be driven by the chaplain. And what we know is in a fee-for-service world, we're not reimbursed for that. That chaplain's time is not reimbursable time. But it's extremely valuable when we look at things like patient satisfaction, when we look at things like how are we impacting their existential stress and pain, physical components. So much of that interpersonal piece goes into how patients receive care, how they receive information about their diagnosis. And so, how are we supporting them on that end? And so, what we've been excited to see is a true transition to that. When we first started this work, you can still see in these numbers, it's very provider heavy, where over this period of time. And I used July because that's when we were really able to stand up our full team. That's when our full team was in place. There are 411 clinic visits, either in person or virtual, that were all provider, whether APP or MD. And when you look at specifically around social work and chaplaincy, of course, they're only 2 people. That's a big difference too. So it illustrates the need for more interdisciplinary team members than just one. But they are seeing a lot of patients. But is there a way to transition even more where it isn't that you see such a large number of provider-driven visits versus was that something that could have been handled solely by a social worker? And in a value-based care model, what is the value to the patient? And also, what is the value to the payer as far as a utilization perspective goes? Because it could be that those needs are met by someone like a social worker or a chaplain that would impact that patient going back to the emergency room, would impact these difficult conversations around what are we doing versus what's really beneficial to your outcomes, what's really seeing a benefit to how you are receiving care. Our RN coordinators have just in the last month started now attending all of the initial clinic visits for patients who are new to the program. And we're already seeing an impact on patients showing up for those visits, specifically because that connection was made prior to that visit actually happening. And then the connection is that the nurse is there as well. But again, you can see up until this point, it was which we see a lot in care coordination, very phone heavy, very messaging heavy, these different modalities to reach out to patients, which of course will not go away. But when you're looking at true care coordination, that patient interaction piece too within those visits is highly impactful, because then that person can help to act as the navigator for that patient. So you can go to the next slide. So we just wanted to end too with just an example of a patient. So we also do this in all of our executive oversight committees, is that we give, the data is great and it paints a picture for sure, but nothing paints a picture better than a patient story. And that's true. I always give a shout out to Jim Ganna with Blue Cross Blue Shield, because he always says that in our executive oversight committees, that he really loves to see this connection of what's actually happening with a patient. And so it's important to anyone who's involved in the care of these patients, whether that's on the provider side or the payment side, But this particular patient, we saw a drastic impact in the utilization of the IDT team for this patient. So having access to social work, having access to the nurse coordinator and the chaplain specifically impacted this advanced congestive heart failure patient. She had less ED visits. Her symptom management from a shortness of breath standpoint was highly impacted. The caregiver was highly impacted for this patient. With the support of the interdisciplinary team, they completed a pulse for this patient, which they had not done before. And the spiritual support, the family spoke specifically about how important to them that their spirituality was recognized and that that was supported as an integral part of their care, and not just a nice thing to do, but actually that it was really important and impactful to how they navigated this care moving forward. We also, Dean spoke to this earlier, but just help make connections from a legal and estate resource standpoint, because this family had not had that either. And so this is just one example, I feel like, of a really impactful story of how these patients' outcomes and just their experience of care is positively impacted. And I'll hand it off to Laura.
Thank you. I just love hearing these, just us together, able to share this with you all. It's very important. And Anna, you can move to the next slide. But it's really enriched my work life. I feel knowing that now, coming from a provider side, I always thought that the payer and the provider just didn't communicate. It was more, there just weren't reasons for it. We protected our patient information, and providers just wanted, or payers just wanted to know about reimbursement and that. And now I'm on the payer side, and it's truly not that way. But up until recently, we haven't had the infrastructure to really communicate with each other respectfully and collaboratively. And so I'm really fortunate to work with the Healthcare Innovation and Improvement Division, where we all know that there are pain points in healthcare. I mean, that's a given, but there are also solutions. And what's important to us, that it's not the lack of innovations, it's knowing which ones to choose, knowing which ones really fit with our community and our ability to make a change. And it's our goal to choose smarter ways to work together and advance the ability to have a sustainable future with these changes. Anna, you can go to the next slide. So we want to innovate with purpose. 4 key pain points where innovations are improving outcomes, cost, and experience are listed here. It's our accountability. So health plans are now working with providers and partners and patients to improve outcomes and lower costs. Our convenience, when care meets the patient where they're at, the member, then that's when they can really get that high touch, really invested attention to their needs. The experience, having a strong consumer experience, really lies at the heart of every successful innovation. And then engagement, starting with each member's needs can lead to a better utilization and create positive change. Anna, you can go to the next slide. So what we know is that patients who have serious, potentially life-limiting illnesses coupled with functional limitations are not well served in the current fragmented intervention-oriented health system. We know this. We also know that there's research out there that demonstrates that high-quality interdisciplinary palliative care services can provide significant benefits for patients, caregivers, and us, and the payer. However, despite knowing this, we just don't have the ability to connect all those dots. Patients and caregivers, they don't receive palliative care because there just isn't that adequate resource connection to allow those appropriate teams to get to that patient at the right time. And, what you see here is we see where we are today at the fee-for-service arena, where reimbursement is driven by volume. It's a heavy reliance on pre-authorization and utilization cost management, and it typically places providers and payers in adversarial positions. And what we're moving toward is the value-based reimbursement, the fee for value, reimbursement that's proportional to the delivery of high quality and cost-effective care. And this is incentivizing clinical and financial performance. Also, it aligns the payer and provider. So, and that's what we're, you hear that over and over in this presentation, that, it's been the most impactful experience for us to see just how well we work together. We all come from the same heart and the same purpose. I mean, we hire the people on our side are RNs. They are in the clinical world. And so having this like-minded individuals connect really breaks down those barriers that were always in place. And Anna, you can go to the next slide. And so this isn't new to anyone, the alternative payment model framework. So we all know where we started in this category 1, and our goal is to, move into that category 4. And that ultimate goal is that downside risk, where both the payer and provider are sharing the risk. But to get there, we have to establish strategies that demonstrate a successful upside only model, right? So we truly want to align we want to take those baby steps with the payer, walking with the provider, so that we can test how this is working. And we can show the provider that working together, aligning our data, aligning our resources, can then move into something that's beneficial to both the payer and the provider. And I think that, moving into the need for the quality, we, of course, want to see the utilization and everything kind of shift, not just not only go down, but, that home-based care where there's really more of a focus on how can we meet this patient where they're at, our member. And so, incorporating those redesigns and infrastructure and workflow allow for that quality data integration and performance data. And we know that's hard to do. It's hard for the provider side to recreate their infrastructure while seeing their patients, while, staying within this fee for service model. But we are also having to increase our own infrastructure in ways that we know we're not just sending you a report that really isn't helpful. We've found over the years that we have great reports, have tons of data, but when you really dig down deep, what is it actually identifying? What is it helping that provider understand their need to, what's a really key area they can focus on improving, but also what are the areas where they struggle most, or that they're doing great, but if they kick it up just a little bit more, they'll do even better and they'll see even higher results and higher impacts in other areas. And so when we do this, it's really understanding that not only does our own infrastructure need to provide more of that provider enablement information, but that we have to also take into consideration, we have to not only, we want to meet the patient where they're at, but we also have to meet the provider where they're at. And knowing that this is a gradual shift is part of that process. You can go to the next slide. What I think is really timely with this presentation is that this research just recently came out. And if you haven't read about this or, heard about this new measurement results that have come out, I highly recommend you look into it. The Healthcare Payment Learning and Action Network, it's run by Deloitte and funded by CMS. And the data that went into this was provided by the America's Health Insurance Plans database, but also our Blue Cross Association database, as well as CMS. So I can get behind the results of this data. And I think it's important to see that we are making a difference. We are gradually moving into a more value-based environment. We're all learning how to incorporate these new practices into our workflows. And, this actually is retrospective data, of course, on actual dollars paid to providers and total lives covered in accountable care arrangements. And I think it's important to really look at categories 3 and 4 don't always have to mean providers take a financial risk. However, that is the goal. That's the ultimate goal. But, financial risk, downside risk means that the payment can vary, and it can vary based on the level of quality or spending performance on the attributed members, and can result in losses in quality or spending that's not in line with the targets. And so that's another reason to really do those baby steps, because you want to establish that budget together so that it's a workable target and it's not something that's just going to demoralize the whole process right out the gate. We want to know that we're going to be successful. But I think it's really important to show that Medicare Advantage had 64.3% of healthcare dollars in categories 3 and 4, and 43% in downside risk. That's significant. Traditional Medicare, also around 42% in healthcare dollars, whereas 33.7 were at that categories 3B and 4. The commercial lines of business had 39.2% of healthcare dollars, where 21.6 were at that downside risk categories 3A and B. And even Medicaid, of course, had 43.7% of healthcare dollars in the value-based arena, in the value categories 3 and 4, where 21.1% were at that downside risk categories 3B and 4. You can go to the next slide, Anna. So I think from here, this is significant for me, and I think Dean and Christina have already really highlighted all of this. This is really what goes into making a program work. But we also, it's so hard to understand what it means on the payer side, and how do we adapt and adjust to meet these new opportunities and make them successful and sustainable. And this is really important, because you really go through these steps and even go back and do some of them again. And there's always that an iteration of really having the model buy-in is a huge, the buy-in is a huge focus for the payer side, because we have many clients for the value-based care. So we not only have the provider, but we have our lines of business, we have our patients and our members, and what are those benefit plans look like, and how do we restructure that to benefit the patient but not step out of the lines of the Department of Insurance. So there's a lot of work that goes into making these programs work for everyone. And so we do go through these processes, and we do go through and pull our own interdisciplinary teams together with our UN managers and the medical affairs folks. We'll bring them in, and we also have our the case managers that speak specifically to that patient interaction. All of those stakeholders come to the table to assist me and our team on how do we approach the provider. And then we sit down with the provider and we go through each of these things, and we let the value-based team, lets the subject matter experts tell us how this will work, what is the best way that this can work, and who needs to do what when, with the main goal being that we don't overburden the patient. We call it member abrasion, where you really can just bombard the patient with too much just people calling and going through all these different things. If you don't have the same messaging, then they're confused and they feel like they're just being given the runaround. And that's what we want to prevent. And a lot of the collaboration that goes into implementing and piloting and scaling these programs really has to do with making sure nothing drops, nothing falls through the cracks as far as the care that's already being provided by our case managers, but also that we align those efforts with the providers' case managers to ensure that that high touch that level of high touch doesn't diminish. We know that it enhances that patient's experience. The ability to meet the patient at the bedside will always trump the payer, and we know that. And so we never want to get in the way of that. We want to leverage that opportunity for the provider by being that support mechanism in the background that just really ensures the information is solid, the most up-to-date information is solid, and that that provider representative can really make an impactful contact. We don't, so a cold call for palliative care is probably, I'm learning, the most difficult issue that we see. And you have one chance. You really have one chance to reach that patient and communicate effectively. And so we've focused our efforts on letting the key subject matter experts, our case managers who talk with these folks day in and day out, those nurses do, like Christina said, get together weekly and really, work as a tandem, as a team to just coach that patient. And whoever it is that needs to be that primary contact, they let that happen, and they just really are making the biggest impacts because they are working together. And through it all, we go back and test it some more, and we move forward, and we continue these collaborations. And it's really been a fascinating opportunity, and certainly not done, and certainly won't be the only one that we do. But I think that this is really, we're at a very pivotal point where we're beginning to really dig into the data and see how this is all going to play out. So I'm glad to be here, and thank you for the opportunity.
Thanks, Laura.
Mm-hmm.
Well, I'm going to suggest that, because we were going to do kind of the three of us kind of go around some of these lessons learned. I think we did a fairly good job of covering most of these throughout. We shared a lot of information. I just want to make sure there's time for a few questions if there are, and if not, we can kind of make some summary points. But I think hopefully you learned that this was amazing kind of presentation and sharing by both Laura and Christina, and I'm just always impressed by the work that they're doing and what we're learning through them. So, Marisol, I'll turn it over to you, because I think just to see if you want to kind of tee up any questions.
Wow. Well, listen, guys, we need to have the grid up and put all the hearts up. This was so amazing today. I absolutely love what you guys have shared, and the possibility for comprehensive care for our citizens in South Carolina as well as North Carolina with looking at this comprehensive pilot. I think the story is what really got my heart. It grabbed me when you hear that it's working, that the team is able to impact a family's life. And so I want to start there at that point, talking about the caregiver and the patient. I saw where you're providing some respite for that's a part of the model. And how many patients would you say or caregivers have been able to take advantage of the respite piece of this? Is this something that has already sort of gotten started, or it's still in the planning phases?
So I don't, as part of the program, just to clarify, as part of the program, we are not supplying respite. I think it comes in more with understanding. I think one big piece for us is understanding the payer benefits. There are a lot of benefits on the payer side of things that I had no idea about. I'm sure our team didn't know anything about. And it is another example of why the connection with the payer has been so impactful, because our case manager talking to their case manager, our CSI at Blue Cross Blue Shield will say, oh, actually, this patient has access to A, B, C, and D. Let's make sure they've gotten that information, that they know how to access that. Mm-hmm. So really, and then on the social work side of things, and I know Keisha's on, she's our amazing social worker who's helping these patients. That's another piece, is having someone who knows the resources or knows who to connect them with to get resources in their particular area. Because many times that's the limitation. I may know as a provider what's immediately available in Charleston because I've lived here all my life. But if someone lives in Florence,
Right.
I don't necessarily know what to connect them with. And so making connections, building those relationships on a regional perspective as well. I think that's been, and also just for the caregivers to say, we're doing a caregiver burden assessment and what's going on with the caregiver, because sometimes they're not voicing that. That also can be very generational. People are very stoic and they believe in taking care of their family member.
Absolutely.
And not voicing the fact that it is really hard and detrimental to their own health.
Yeah.
And so taking just the necessary step and asking those questions, helps to connect them with the things that they need that we may not otherwise know about. And so there are so many aspects, I think, to this program that have enhanced the care that we are providing, in a way of structuring the aspects of what we're talking to these patients and families about. So,
that is so good, Christina. I wish we had a whole nother half hour, right? It's 1:27. But I'm glad you clarified that. And I know Keisha well. She's so engaged with the work. And many times, we're sort of doing highlights to the coalition of those organizations that are statewide, that like the Respite Coalition, like, Meals on Wheels, or things that as the social workers are making their assessments, they're able to connect people to those, to those groups to really, help caregivers. And, we do have that sort of South Carolina pride. We there's cultural pride, then there's South Carolina pride about the help we will accept and the help we might not accept, right? And so I do appreciate the spiritual pieces, working with social work. And Keisha, I saw where we spotlighted you. Did you want to add something to the conversation? Love to hear you.
Well, I was just gonna say too, oftentimes we will get called in, and I appreciate it when you said, the goals of care discussions, because oftentimes I will get called in on some of those. But it is a lot of resource management that takes place, as far as being a social worker. I do think, Christina, you kind of failed to mention the good part, about being in this clinical role also is being able to provide some therapy, some brief therapeutic interventions for some of the patients. Is one of the things that I've been able to do for a lot of our patients, and that's been a huge bonus as well, because even though we can make referrals for behavioral health, we know it's a long time before they can get their appointments and things like that. And so for a lot of people with the adjustment to illness, I think that component has been really great, just to help people navigate a new diagnosis and things like that. So just wanted to put that part in there too.
Thank you for adding that, Keisha. And that was remiss of me to fail to mention, because that is a huge role that Keisha plays for our patients and their families. And why we put it together the way that we did. We really wanted someone who had that clinical counseling expertise to be in that role, because we know that the mental health portion of this care is so important.
So impacts the patient and the caregivers, right? And so you guys have the right team put together: spiritual care, social work, the nurses. I'm a nurse, so shout out to the nurses for having those initial contacts, and certainly the administration piece, and having a wonderful payer partner looking at these pieces as well. So, guys, I tell you, this has been wonderful. We will send out the evaluation link, so give us your feedback, other topics that you'd love for us to cover. This was just a really amazing closeout of our 3 days today. I just absolutely wish more people could have heard it, but we're going to push out the recordings, letting people know that. And absolutely, the slides were great as well, and we'll get those to all the people who registered. And knowing me like I know myself, I'll probably open it up even to the people who didn't register to come and send those slides out to the whole network. So so that they can get this information. So everyone, thank you again. One reminder, we will not be having our monthly meeting this month because we've had these 3 days together from 12 to 1:30. So do disregard the calendar appointment for the third Wednesday monthly meeting. We will resume our meetings next month, as well as the Education Committee. We would have been meeting next week, but we're going to meet in May so we can do our evaluation. However, our palliative care scorecard ad hoc committee is on deck and absolutely on track to meet the fourth Monday from 12 to 1. And if you're interested in that, we're looking at how we can get our palliative care score up for South Carolina. And so we have an ad hoc advocacy team working on that with the coalition. Once again, thank you, everyone. Thank you, Laura, Dean, Christina, and Anna. Appreciate you guys. Have a wonderful afternoon, everyone. Bye-bye.